The first 15 minutes we're going to spend kind of reviewing in general Parkinson's medications, what medications are out there, what new medications are out there. There are plenty of options. And kind of one thing I like to tell my patients, and one thing to always keep in mind, Parkinson's is not a cookie cutter disease, right? No two patients are the same. And you'll see through my slides, there are so many options, there are so many medications that are out there, and so many different combinations and cocktails of medications that just because this person's on this one does not mean why am I not on that one, or should I be on that one, or well, this happened to me when I was on that one. Is that going to happen to me? Is that also going to happen to me for someone else? So not the case at all, which is what makes this disease very, very unique from that perspective, is that every single person is very, very different with this disease, and their disease process is going to be different, their medication regimen is going to be different. So, hang on. So, biggest thing we talked about, right? So, and remember, nobody dies from Parkinson's, you die with Parkinson's, but it can affect someone's quality of life. And so our job is to work together to improve and maintain the best quality of life. And I like this slide because something to keep in mind, and what we'll talk towards the end of this presentation about, is if you think of Parkinson's as a glacier or iceberg, the tip of it is really just the physical things that you see, the slowness of moving, the stiffness, the tremor, the walking issues. But underneath, just like a glacier, there's a whole slew of different non-motor features. The mood issues, the constipation, the confusion, the drooling, the dizziness, all that stuff which really impacts someone's day-to-day quality of life that could be a little bit that's more problematic than their tremor, say. So when we're approaching and treating the disease, it's not only important to talk about dopamine and the different medications involved in terms of treating quote-unquote Parkinson's, but we're also treating a whole slew of non-motor stuff that's happening underneath that also needs to be, it's a daily conversation with patients when we're seeing them in the office. So, as I mentioned, Parkinson's, for whatever reason, if we all live long enough, we're all going to get Parkinson's. For whatever reason, Parkinson's disease patients lost their store of dopamine before anyone else. So you see here, dopamine is sort of the oil of our nervous system and getting us to move smoother and move easier. And when we lack that and that dopamine is not there, these are the sort of symptoms we start developing. So the biggest thing, and this is a busy slide, but something important in terms of when we're talking about medications and treating Parkinson's, the goal is just that, is how do we get that dopamine back? Let's give patients dopamine. And so there are multiple different ways that we could do that. And so this is sort of your scheme in terms of how we come up with medications for Parkinson's. What are we looking at whenever we're thinking about Parkinson's disease and medications for Parkinson's disease? So, okay, let's think about, let's give them dopamine. If dopamine's missing, let's create dopamine and give patients dopamine, and that's what levodopa is. Levodopa becomes dopamine in your body, in your system, and so the first main category of medication is just that, is dopamine. It's a dopamine precursor, becomes dopamine in your body, so patients can start feeling better. And so then the other option is, well, can we trick the brain to thinking that they have dopamine? And that's this idea of a dopamine agonist, which the receptors that work where dopamine can act on, can we come up with medications that can trick that receptor to think, oh, this is that dopamine. Okay, I'm going to react to that, and I'm going to like that, and the patient's going to start feeling better. The dopamine that's still in your system, or the dopamine that you're getting, can we keep it in your system for longer? Are there ways to prevent it from breaking down? And that's sort of the next couple of categories of medications. There are multiple enzymes that work in your body to break down dopamine, and are we able to prevent that breakdown so that dopamine lasts longer and can make you, if it's lasting longer, it's in your system longer, you're going to feel better for longer. Are there ways to counter the dopamine? Are there other medications out there that could potentially work against the dopamine that works in balance with dopamine? If you have dopamine, you have other things. Can we work where, okay, dopamine's going down, this is going too high. Can we counter that by lowering that so then the effect of dopamine is there for longer? And so really the whole point of this is that there's always something else that's coming out. There's always other options or other routes or other ways to create this dopamine, what we need, without having to think about, okay, what else can we potentially do? And This slide now gives you, you can see there are over 20 different options and different medications that are out there in terms of when you separate them from category. Yes, the main treatment, we talked about, is levodopa. Levodopa becomes dopamine in the brain. Levodopa is the oldest treatment for Parkinson's and still to this day the gold standard treatment for Parkinson's disease. When they first came out, they thought, okay, we have the cure for Parkinson's. This is dopamine. Give everybody dopamine. Everyone threw up. Nobody tolerated it. Right? So then realized levodopa was becoming dopamine in the stomach instead of where we want it to be. We want it in the brain. And so how do we come up with a way of getting levodopa to the brain? And so that's why we now have carbidopa/levodopa. Carbidopa carries that levodopa to the brain where we want it to be for it to become dopamine in the brain. And so you get the name Sinemet. Sinemet's Latin, sine without, emet, vomiting, without vomiting. And that's how you get Sinemet. And so then patients were put on Sinemet, and with Sinemet, there's now become multiple different types of formulations, a controlled release formulation that for patients who may not tolerate that surge of dopamine, that surge of immediate release, maybe a slow trickle, maybe a little bit easier for them to tolerate. Rytary, which is an option in terms of extending long-acting dopamine. And you'll see here multiple different options, and we'll go through different things. And so we take each category, talked about this already. Rytary is sort of your capsule of extended levodopa. You have Parcopa, which a lot of times when patients are admitted in the hospital, this is the option for them. It dissolves in your mouth. So you don't have people who, if you have issues with swallowing or something, that you still are able to get carbidopa, levodopa, but you get it through something that dissolves in your mouth. If we realize with time that as patients go on, they realize your dopamine levels are fluctuating, they're feeling good for a bit, but it only lasts for an hour or two, are there other options there? There are dopamine pumps. Just like for diabetics, there's insulin pumps. Parkinson patients, there are dopamine pumps. So there are options where you could get that same levodopa infused in your system throughout the day, all day long, to try to keep you smooth throughout the day. Rescue inhalers. Asthmatics get a rescue inhaler, they're not feeling that well, they take a quick pump, they start feeling better. Parkinson patients, you're slowing down, you may not feel that well, you have about an hour to go before you're due for your next dose, a quick pump that will go through your lungs to get a quick onset that you feel better and bridge you for that hour. So lots of different options, lots of different ways to come up with in terms of making sure patients get what they need fastest, easiest, and throughout the day consistently. Most common side effects, we talked about the nausea, it's just so there. You'll see in terms of the side effect profile as I go through these medications, a lot of them are all very, very similar in terms of they're all pretty much side effects of dopamine in general. So less commonly confusion, hallucinations in regards to compared to the other medications. Some quick tips to keep in mind. Generally, we start off with 3 times a day. What I tell patients, 3 times a day does not mean morning, noon, and night. 3 times a day generally is symptom control. 3 times a day while you're awake. So some people who are sensitive to, with food, they'll take it before or after food. I have my patients start off just in general, breakfast, lunch, and summers. It's breakfast, lunch, and supper. It's hard to remember to take anything 3 times a day, but most people remember to eat 3 times a day. And so if you generally do that a few hours apart and you get the most bang for your buck and you take your medications throughout the day. Dopamine agonists, the receptors that could trick the brain to thinking that it's dopamine. There are about 4 different kinds of those options, including one that's a patch and an injection, a rescue injection. Similar idea, you have an hour to go, you give yourself an injection to hold you over for about an extra hour. There are pumps that are coming out with this too. One thing to keep in mind with injections, you could get withdrawal effects from it, or with dopamine agonists. So keep that in mind and always talk to your doctor with this may be an option for you. Works very well, especially for tremor control. Older patients may have a little bit tougher time tolerating it, but again, very effective in terms of improving patients' symptoms, especially a tremor. You'll see this slide repeatedly. What we know about Parkinson's disease, as the disease progresses, the goal is to try to stay in this middle white zone of where you feel comfortable. You're on, your symptoms are good, you feel good. And as the disease progresses, that window gets smaller and smaller and smaller. And the goal of treatment maintains to try to keep patients in that zone as long as they possibly could. That means medication sometimes, as the disease progresses, takes longer to kick in. When they do kick in, they may overshoot, and you get the extra movements like Michael J. Fox. And so if you want to maintain that goal, and that's the goal of treatment, and whether that is through different medication injections, whether that's through surgery, the goal is going to be always to try to maintain you into that zone. And that's where these enzyme inhibitors that keep the dopamine in your system longer, to keep you in that zone for longer. 3 different types of medications related to that, very well tolerated, rarely any issues in terms of side effects, but 3 options from there that are there too. Selegiline, one thing to keep in mind, if a patient is on selegiline, it is twice a day, but the second dose is, generally patients should take it before noon. It breaks down into an amphetamine component that could keep you awake, and we know Parkinson patients already have issues with sleep. So ideally, you want to take your first dose in the morning, your second dose before the afternoon, so you don't have much of an issue related to that. Other types of medications, this helps in terms of increasing levodopa in your system for longer as well. Again, 2 types, and a third one that is combined with carbidopa levodopa to have 1 pill that has 3 different medications in it. And then when we're having these extra movements, what options are there? Can we do something that when people are moving around too much, generally patients would prefer that on period instead of being too slow and stiff. But if the dyskinesias are bothersome, you're moving around too much, you're exhausted, you're falling, what can we think about? And amantadine can help significantly by decreasing that. And there are 2 extended releases that are out as well now. That for patients who may not tolerate that immediate release, there are options for once-a-day medications that you could be on. That's an extended release amantadine to keep in mind. And one of the newest ones that came out is looking at not a dopamine at all, looking at another mechanism of action that can help regulate dopamine. Adenosine, we know in our system, that sort of works alongside dopamine, just sort of keeping it. If you think about it as your body being a car, your dopamine is your gas pedal, adenosine is the brake pedal. So if you're lacking dopamine, you're not able to move, but if you ease up on that brake, maybe you can move a little bit more. So if you block the adenosine, then we can now potentially get a little bit more movement going. And so that's the idea behind Noriance, which is one of the newest medications that has come out. Again, trying to increase the effects of levodopa, remove that brake a little bit, see if you could speed up and move a little bit easier. Once a day, with or without food, similar side effect profile. The pump we'll touch on, it's the same medication. It is levodopa, except it's infused. You wake up in the morning, you give yourself a morning bolus to get yourself going. You have a constant infusion all day long. If at any point through the day you're feeling slower or stiffer, you could give yourself an extra bolus dose at the end of the day. You disconnect it, flush it with tap water, you go to bed. So an infusion of levodopa all day long. And for time's sake, I'll briefly touch on, these are other medications. Again, these non-motor symptoms, confusion. We know we have Nuplazid, pimavanserin, which is available for patients who are having hallucinations. Truthfully, the commercial is very scary. Don't watch the commercial. Does that mean you're definitely going to have hallucinations? No. And a lot of patients will tell me, yeah, I see them. I know they're not real. It doesn't bother me. Leave it alone. But if it is bothersome for patients and for caregivers and they're having issues with delusions and things like that, there are options available to talk to your doctor about. Dizziness when you stand up, your blood pressure may be dropping when you stand up. Different tips to keep in mind here if and when that is happening. And there are, again, medication options that are available for that too. If you're getting too dizzy, your blood pressure is dropping significantly, which can happen with Parkinson's disease as well as the side effect of Parkinson's disease medications. And a lot of times Parkinson's patients have already had a history of high blood pressure or something like that, and they've been on these meds. So see if we could remove some of those meds and we're still dropping our blood pressure, then there are options for treatment for that. And finally, drooling. Parkinson patients may realize that they are a little bit over the pillow overnight, no big deal. But if you're having to walk around with a handkerchief, that could be a problem. And we could inject a little bit of botulinum toxin to help kind of dry up the mouth a little bit so that it's more of a quality of life component. The most important treatment, and you'll have a topic dedicated to this later on today, but I'll leave with this in terms of the most important treatment and the mainstay treatment for Parkinson's is exercise. Above and beyond any of the oral medications that I've talked about already, one thing to keep in mind, exercise, exercise, exercise. That's going to do way more for you than any of the levodopas and things that are out there in terms of longitudinal effects and things like that. So keep that in mind, and again, there'll be plenty of talks showing the impacts of exercise. So no two patients are the same. If you're having a problem, talk to your doctor about it. Do not feel like you need to slow down or wait to be treated. Quality of life, to keep that in mind, because that's what we want to do to help improve your symptoms as they're happening. And I will stop there. That was a lot, but we could talk more offline, or if you have questions regarding specific medications, I'd be more than happy to address them.